To get started. Thank you so much, everyone, for joining us, and just want to welcome you to the Essential Substance Abuse Skills webinar series. I'm Kate Trans, and today we have Steve Steiny to present Counseling Families, Partners, and Significant Others. This training series is brought to you by the National American Indian and Alaska Native Addiction Technology Transfer Center. We are part of the ATTC network, which also includes 10 regional centers, 5 international centers, a network coordinating office, and the National Hispanic and Latino ATTC. In the next couple of days, we will send out a follow-up email to everyone who attended, and this will include a link to the recording, handouts of the slides, and a CEU request form. Our center is a NADAC certified educational provider, and we'd be happy to provide you with CEUs for a $15 fee. Immediately following today's webinar, you will be redirected to our GIPR evaluation. This survey just takes a few minutes to complete and asks about your satisfaction with the event. This feedback is critical to our future work, and we value your opinion and would greatly appreciate your time in sharing your thoughts with us. You will be muted for the duration of this webinar, so please use the chat pod to share your questions and comments, and we will address questions at appropriate points during the presentation. Today's speaker is Steve Steiny. Steve is our program manager for the Tribal Opioid Response Project with the ATTC and has been an alcohol and drug counselor since 1997. He has worked in the behavioral health services and nonprofit sector for the past 23 years and has been in recovery for over 31 years and has committed his life and his profession to helping others in the recovery process. And I just want to mention that we were planning to have Sean Baer join us for this to speak to the more of the cultural aspects of counseling, and unfortunately Sean couldn't be with us, but he will be joining us on some of our future webinars so we can incorporate more of the cultural components. So I just want to thank you all again for coming today, and I'm going to pass things over to Steve at this time.
Thank you very much, Kate, for getting me set up today and getting ready to go for today's presentation. I want to say good morning or afternoon, depending on where you're located. So hello to our friends perhaps in the Alaska area, out west, and certainly in the middle part of the country, as well as the eastern parts of the country if you're listening. Nice to see so many join us, and I really do appreciate you all taking the time to be part of this discussion today. Hopefully we'll have some time at the end to do some questions, and I will try and respond during the presentation if I can as we go. So looking forward to sharing some information with you today about counseling families, partners, and significant others. This is a part of our Essential Substance Abuse Skills webinar series. I'm relatively new to the team, so bear with me as we go through this together. And I hope everyone can hear me okay. But before we get started, I also want to thank our program director, Dr. Skinstead, and our co-director, Sean Baer, for giving me the opportunity to share with all of you this PowerPoint presentation regarding working with families and partners and significant others in the counseling process. As Kate said, I am broadcasting to you live from the National American Indian and Alaska Native Addiction Technology Transfer Center here in Iowa City. I am on campus at the University of Iowa and located in the College of Public Health on campus. So our national center now includes 3 technology transfer programs in the area of addiction, mental health, and prevention. Our current projects include Tribal Opioid Response Technical Assistance, Mental Health Technical Assistance for K-12 schools, and our new Tribal College and University Initiative. We also host a Leadership Academy for American Indian and Alaska Native behavioral health professionals. You can find more out about this on our national ATTC website. And just wanted to share too our mission. Our mission here at the Addiction Technology Transfer Center is to serve as subject matter experts and key authorities on resources for culturally appropriate prevention practices, addiction treatment, recovery, and mental health services. In these roles, we aspire to support behavioral health professionals working with American Indian and Alaska Native communities. We focus on using evidence and experience-based methods for treatment of those challenged with substance use disorders and other behavioral health disorders, and providing technical assistance to communities in crisis due to a mental health or addiction epidemic by partnering with local AI and AN behavioral health workforce members. We utilize indigenous knowledge to create culturally informed experiences for providers and patients. And again, you can check out our website for more information. So why don't we go ahead and get started? Again, my name is Steve Steiny. I'm new to the team, although not new to the area working in addictions. I'm a certified addictions counselor in the state of Iowa, and though I'm not a licensed or trained marriage or family counselor, I have worked for many years with patients and their families and partners, because we know that substance use disorders impact and behavioral health issues impact the family first and foremost. So let's go ahead and get started. See if I can advance my slides, and Kate, you can back me up if I'm having difficulty. So our goals and objectives here, and we're going to try and cover a lot of information. We may not be able to dive too deeply into the information we're going over today, but I want to make sure we at least touch on some of these things, and maybe we can circle back and do some questions and answers, or any of you can reach out to me here at the center if we want to talk following today's presentation. But the goals and objectives really are to understand the characteristics and dynamics of families, couples, and significant others affected by substance use. Also, to be familiar with and appropriately use models of diagnosis and intervention for families, couples, and significant others, including extended kinship or tribal family structures. I did have a chance to speak with Sean Baer, our co-director, who is native Meskwaki, last week, and we did talk about some of the differences between Native American family structures and traditional family structures. So we'll address that later on in the presentation. Also, to assist families, couples, and significant others to understand the interaction between family systems and substance use behaviors. And then lastly, to assist families, couples, and significant others to adopt strategies and behaviors that sustain recovery and maintain healthy relationships. So let's jump right in. Like I said, we have a lot to cover, so I'm going to move fairly quickly. If there are some questions that come up, I'll try and have Kate tag those, and we can circle back to them later, okay? I hope you can all hear me okay. So some of the reasons why you would want to utilize family therapy in the counseling process. Certainly to build upon the family strengths that already exist, to improve communication, to decrease conflict if possible, and to reduce the impact of substance use disorders, mental health issues, or significant change events within the family dynamic. And I'm sure that we could probably think of some others related to that peripherally, reasons why we might use family therapy approaches in treating the identified patient. So one of the things that I think is a key term is just the term family. And I reviewed these with Sean Baer, and we talked about some of the differences between let's see if I can get my, Kate, can I get my notes section up? I'm having a hard time seeing my notes.
Yeah, sorry about that. The button that turns it on and off is right next to the arrow, so it might have accidentally hit it there, but
yeah, I'm not seeing my notes. at all.
So they actually show up. I can run over and show you too, but they're.
Let me see. Oh, there we go. Yep, I've got them now.
Okay.
Yep. Thanks for bearing with me, everybody. I'm still getting used to the system. So reasons why we would want to involve the family. We've listed those. And many times the answers are in the family. People know their situations and resources, and we can use these to mitigate issues related to substance use and then or other issues and find alternatives to cope with these, other skills to work through these. So again, let's go back to this idea of family. I think it's important to note that the idea of family means different things to different people. So I had sort of done a search to see how different definitions of family were defined over time. And as you can see, going back even to the 15th century, family meant household in many European nations. And it also, so the modern use of that term came from this, really talking about those connected by blood, whether living or not. This was first noted in the mid-1600s. And it's important to note, and Sean pointed this out to me too as we talked about this, there's the nuclear family, and then the idea from the native perspective is more an intergenerational sense of family. So this idea, some of these ideas were not based upon native family systems. Even the buzzword family values really didn't come up in modern culture until 1966. Family could also mean a group of relatives, people who are closely related by birth, marriage, or adoption. Okay, so, and then just lineage, all the people who are descended from a common ancestor. And for Native Americans, family went far beyond just their parents and siblings. So that was something important too that Sean and I talked about. Family therapy defined. So this is again something that I wanted to at least kind of put out there as we start to talk about some of the different approaches and systems utilized to involve family in the treatment process. And it's important to remember that native family systems are not based upon this nuclear family system idea. But family therapy is really defined as often seen as a type of psychotherapy that involves all family members of a nuclear family or step family, and in some cases, members of the extended family or adopted family. And then there's some examples. So grandparents, foster parents, legal guardians. And then the idea would be a therapist or a team of therapists conduct multiple sessions to help families deal with important issues that may interfere with the functioning of the family, a patient's recovery, and the level of support in the home environment. Okay. So again, when we look at this idea, some key concepts to keep in mind. A whole system is more than the sum of its parts. I know some of you have probably heard that statement before. Parts of the system are interconnected. Certain rules determine the functioning of a family system, and systems are dynamic, carefully balancing continuity against change. So think about rules, roles, and the systems in place. Tribal families may consist of an adopted family. They may consist of adopted family members, not a formal sort of European adoption process, but rather a traditional native adoption sense of the word. Sean talked about that with me as well. So I'm learning. The purpose of family therapy is often to help family members improve communication, solve family problems, and understand and handle special family situations, such as perhaps someone passing away, or divorce or separation, serious injury, substance use, mental health, or other issues related to maybe an adolescent in the home. And then the idea would be to create a better functioning home environment. So the description of family therapy really is typically the family therapy is initiated to address a specific problem. Could be an adolescent with mental health concern, could be a substance use issue, it could be an adjustment to a death or significant change in the family structure. Frequently, therapy sessions reveal additional problems in the family, such as communication issues. In a therapy session, the clinician would seek to analyze the process of family interaction and communication as a whole, and not take sides with a specific family member. Therapists who work as a team can model new behaviors for family throughout their interactions with each during a session, perhaps even a group session. Some of the challenges that I wanted to at least review with some of you, and I think any of you who have done any work with families have probably experienced some of these challenges or barriers to getting family involved. I know that engaging all parts of the family can be very difficult. The who, what, when, and how must be given really careful consideration. In my experience, from a clinical perspective, the provider must have the proper training and support before proceeding, or running the risk of causing additional harm to the patient and his or her family unit. Always consult with your supervisor. Sometimes making an appropriate referral is necessary if you're attempting to conduct formal family or couples therapy, which is maybe outside the scope of your practice or training within your agency. Involving family members peripherally, however, or in small portions of the patient's overall treatment may be a better option for gauging the extent of the family's influence and relationship to your identified patient. I hope that makes sense. And we can look certainly at some of the different challenges involving the family. Sometimes involving that family member may potentially do more harm or increase the conflict because that other family member may be impaired or struggling with their own issues that could impact the identified patient's treatment experience. So I think these are some things to keep in mind as you determine or decide with your team or with your clinic whether or not to involve family. If I can involve family in the treatment process, any opportunity I get, I will do that, but you must take some things into consideration. Hope that makes sense. So let's talk a little bit just foundationally. Really, we look at therapy or counseling in two sort of main perspectives. One is individual therapy. So this can really provide concentrated focus to help the patient become more fully themselves, become the person that they perhaps are trying to become. Family therapy, on the other hand, really believes that the dominant forces in our lives are located externally in the family. Family treatment is directed towards changing the organization of the family. Okay, let's keep going. I hope this is making sense, and I know I can't see you guys out there, but hopefully there's some heads nodding, and some of you may have some experiences working with families when you're engaging with your patients. So let's look at some different perspectives. So one of the perspectives that I think is important to look at is by a gentleman, sort of one of the forefathers of this idea of family therapy. Murray Bowen, born in the early part of the 20th century, he really looked at the comprehensive view of human behavior and human problems. Unresolved issues with our original families are the most important, and centered around two counterbalancing life forces: togetherness and individuality. Differentiation balancing thinking and feeling. This is really what he looked at. He was actually trained as a physician early on, and then in the 1950s moved towards working more in the psychiatric field as he felt more drawn to this, and really laid the foundation for what we really term now as family therapy. But after defining the field of family therapy, he started integrating concepts into this theory. None of this had previously been described in the literature, and was being connected with Freudian theory. And what he really wanted to do was move beyond that, and he aimed his theory on working with the family to replace some of the earlier Freudian work. Experiential perspective, again, is another perspective on engaging family, working with the family. It's largely founded in the idea that cause and effect of family problems is emotional suppression. This was designed to change families by changing family members. It also involved families being treated as groups of individuals more than as systems. And enhanced sensitivity and expanded awareness are essential aims for this experiential perspective approach to treatment. And lastly, just focus on interpersonal change and a commitment to growth as opposed to problem solve. Next, we'll move into sort of a combination of two theorists. This is the strategic perspective. Let's see if I can advance my slide here. There we go. Let me back up. Yeah, looks like I skipped one. So first we'll talk about structural family therapy. Again, this was ways of looking at families. Techniques included reframing, punctuation, unbalancing, restructuring, enactment, boundary formation, working with spontaneous interactions, intensity, and shaping competence. In the structural family approach, every family has a structure, and it's revealed when family is in action. And really, this approach really saw the family as the identified patient. They looked at different areas, different subsystems within the family: spousal, parental, sibling. They also examined boundaries, identifying whether those boundaries were clear, rigid, or diffuse. And in addition to the structure and subsystems and boundaries, they really were based on roles, rules, and power. And this structural family therapy, although I never practiced this, really placed a lot of emphasis on terminology, and it was really viewed as easy to apply. There was clearly defined terms and procedures. Even an inexperienced therapist could conceptualize these concepts and apply them. The emphasis on symptom removal and reorganization of the family was stressed, and changes in structure contributed to changes in behavior. The goal really for the structural family therapy is to change the family structure so the family members can unite in a healthy, productive way. Marriage and family therapist is really seen as an observer and implicitly an expert in the session. And there's a lot of information about structural family therapy. It's been around for a while, and it's certainly worth looking into if you're interested. Just for the purposes of time, I'm going to keep going and see if I can at least any more comments about structural family therapy. Okay, let's keep going. The strategic perspective, as I had mentioned prematurely, was really derived from a combination of Ericksonian hypnotherapy and Batesonian cybernetics. And again, not overly familiar with either of these approaches, but just to give you an idea, both of these perspectives developed a really strong body of powerful procedures and techniques, and they vary in the specifics of theory and technique. Erik Erikson really broadened the development perspective beyond early childhood. He wanted to establish a balance between ourselves and our social world. This was really that kind of that biosocial approach. And then in the Batesonian, Greg Bateson really used. He really was he was a social scientist, a linguist, and a visual anthropologist. He was also a semiotactician, which was the study of signs and symbols as elements of communicated behavior. He really looked at the paradox, self-contradictory statement based on a valid deduction from acceptable premises. He focused on feedback loops and metacommunication, rituals, and general systems theory. Both are worth looking into if you're interested in learning more about either of those approaches. The cognitive behavioral perspective, really in this approach, the clinician is seen as a teacher and a substitute. They're really trying to substitute for positive controls. Family systems are treated as learned responses, involuntarily acquired and reinforced. Focus on subsystems considered central to the targeted behaviors. A lot of times contingency or contract management was used in this approach, some operant conditioning, role rehearsal, and the PREMAC principle, which really is using it's based on this notion of using high probability behaviors or preferred activities to reinforce low probability behavior or non-preferred activities. So those are just some general perspectives. Let's take a look at some current perspectives. Those are more sort of foundational perspectives. Let's look at some current perspectives as we move forward. First is the solution-focused perspective, and I really like this one. I was able to utilize the solution-focused or brief therapy approach during a project several years ago where I know I utilized this family therapy approach for a youth project that I was involved in, where we were comparing involving the family in the treatment process and whether that had an impact on treatment outcomes. And we were trained in this solution-focused therapy. We were trained not to even use the word problem. We had to identify any concerns as issues. It was really meant to keep things focused only on the positive and future-oriented goals. This solution-focused perspective It was very pragmatic, minimalism, cognitive emphasis, and easily teachable techniques. There was a de-emphasis on history and underlying pathology. Patients concentrate on solutions rather than on problems, and they have little to say about how problems arise. It took me a while to get used to this approach, really almost at times dismissing past problems and really focusing on the future. Some of the prominent contributors are listed below there, and each of them contributed in their own way, either to the solution-focused approach or in the brief therapy approach. And again, I think for purposes of time, I really won't go into each of their contributions, but if you're interested, I can certainly make some of my notes available to you. The narrative perspective, I think, also is interesting simply because the stories and narratives have existed for as long as humans have had language. They have often brought meaning to the world and have allowed for history and tradition to be related through generations. How we respond to stories or narratives is the concern of narrative therapy, both the ones we create ourselves, but also those that are ascribed to us by others, whether it's culturally or in the wider societal picture. Through narrative therapy, in collaboration with a therapist, it's suggested a person can discover and reauthor their own problem-saturated stories, which again, I think I've only used the narrative perspective, and I think we may all use this to some degree in our everyday lives and even in the work we do with patients. But this pure form of narrative perspective is something worth investigating if you're interested. It's personal narrative and social construction, narrative truth versus historical truth, incompatible with systems thinking, and has distanced itself from the concepts and methods of traditional family therapy. So again, if you're interested in some of the techniques or examples, I would encourage you to look into that. Functional family therapy, also known as FFT, is really concerned with the function that family behavior is designed to achieve. It assumes that most family behaviors are attempts to become more or less intimate. It also it sets up contingency management programs to help them get the kind of intimacy they want more directly. It blends strategic and behavioral therapies. This really was designed and targeted towards treating adolescents, and I know that it also is something that I was familiar with. This model was used in our local juvenile court systems here in Johnson County, Iowa, for many years, and recognized as an effective way to engage families of high-risk youth on juvenile probation through extended longer-term therapy that involved a parent or guardian or family member in the youth offender's behavioral treatment process. But it really targets youth between ages 11 and 18 from a variety of ethnic and cultural groups. It also provides treatment to the younger siblings of the referred adolescents. It's an interesting approach. It's very family heavy. The core principles of functional family therapy is so named to identify the primary focus of the intervention, the family, and reflect an understanding that positive and negative behaviors both influence and are influenced by multiple relational systems. It's an interesting approach, and again, just due to the interest of time, I do want to keep moving so that we have some time at the end to take questions. The family disease perspective, again, I think is something that encourages people This approach really encourages people to fight problems with medication, support groups, and education rather than to explore the network of relationships in which their problems were embedded. The first framework of the family disease perspective to arrive in the field of addictions was the disease model. This approach was a natural development from the 12 steps of Alcoholics Anonymous, combined with the view that addiction is a disease. It's important too, I think, to keep 12-step approaches in mind as we talk about supporting the patient, spouse, partner, and family, and involving them in the healing process, involving them all in the healing process. Al-Anon and NA or AA continue to prove themselves as promising practices. However, these types of limited evidence-based practices are often overshadowed, dismissed, or misunderstood as purely anecdotal by the field, the addictions field or behavioral health field, and other evidence-based practices of today. There is some merit to this family disease perspective, and it's important not to dismiss the 12-step approaches in engaging families and patients. I want to talk a little bit too about the multi-systemic and multi-dimensional perspectives. This resulted out of research with difficult adolescents. It involved a combination of techniques and actively considered and intervening into the extrafamilial systems in which families are embedded. This approach, known as MDFT, was developed by Dr. Howard Little from the University of Miami in 1985. Multidimensional family therapy is an integrated, comprehensive, family-centered treatment for teen drug abuse and related behavioral problems. MDFT focuses on key areas of the adolescent's life and provides an effective, cost-efficient treatment. In speaking with Sean, our co-director, from a native traditional teaching perspective, he shared with me that it is said that each individual should re-examine their beliefs by starting where you are at and begin to work to your earliest memories of how you became to believe what you do and resolve them from this point of view. I wanted to share too just some general strategies that I identified having worked with families in the past, and just some very simple basic tips and strategies to ensure a better family session or couple session. Again, just some basic techniques and strategies that I would offer to you. You wouldn't think so, but proper seating is very important if you're meeting with family members and your identified patient. Making sure that everyone's distributed equally around the room. Calm, comfortable environment. Sometimes it's important to meet separately and then together. Perhaps meeting with the patient before the family comes in, or meeting together and then separately after a time in the session. A rapport with identified patient is important, and be prepared with an agenda, but as most of you know, you have to be flexible too if the need arises to set down your agenda and to really focus on maybe an immediate concern. It is a process. That's the other thing to remember. You have to allow for several sessions to reach goals and objectives, and you may not reach those goals either. Modeling communication, and then managing conflict and any negative language with redirection. Sometimes I would, if conflict became too much during the session, we might take a 5-minute break and then reconvene after everyone has had a chance to calm down. I hope those are helpful. Let's keep going. I want to make sure I'm watching my time. Let's take a look now at some cultural considerations. And again, I had a chance to speak with Sean Baer so that he could give me his thoughts and ideas about some of the areas we'll cover in the next few slides. Certainly, I want to consider just the definition of family of origin. The birth or biological family or any family system instrumental or significant in a patient's early development. So I think that's important to keep in mind, how powerful the family is and what an important role they play in developing the family members, the children and siblings in that family. Some cultural considerations. Increased immigration and contact with the global media exposed cultures. Asking yourself, is your own worldview healthy? And I think it's important to remember, too, that differences aren't necessarily problematic. And I thought this was an interesting point as well. Overemphasis on ethnicity can lead clinicians or counselors to exaggerate the differences between themselves and their patients. Ethnicity is a powerful meaning generator. And I often found myself looking for similarities within those patients that were vastly different from me. This sometimes afforded me an opportunity to then see our differences in a new light. I hope that makes sense to some of you. Race and ethnicity. So again, looking at American Indian, Native Americans, and Alaskan Natives. One of the next slide, I was hoping to have Sean here to review this together, but I talked with him about this slide, and I think overall what I took from our discussion is that from a Native perspective, the family structure is very different from the traditional sense of family structure. For Native Americans, family went beyond their parents and siblings. I wanted to say too that, so Sean was sharing this with me. He said that from this view, this Native American family, based on some of these Native traditions, a brother or sister, from this viewpoint, all of the cousins are also brothers and sisters. And then if we take that further, from this view, all the aunts and uncles are viewed as parents. Aunts act as mothers, while uncles may tease the children in a fun way, yet are also the enforcers of respect and order to keep children on task. Sean said there was no physical punishment or abuse of any kind, as this was not a traditional Native practice. Even from a clan perspective, some tribes cannot date or marry someone from another tribe who is from the same clan, as they are deemed to be related. Even older traditional practices may consider all grandparents, even from another tribe, as a grandparent. This is partly where respecting elders comes from. So as you can see here, this really is showing the grandparents across the top of the slide, and all of these grandparents would be considered grandparents to all of the mothers and fathers and uncles and aunts. And then all of those parents would be considered parents to all of the children. This next slide, again, talking with Sean about this concept. These, he explained to me, are the 7 values of the way of life for the Dakota, Lakota, and Nakota. Although other tribes' value systems may differ slightly, these are very common among the tribes, sometimes referred to as the seven grandfathers. And you can see here the different values noted accordingly. So I want to shift now to the next portion of our presentation to really talk a little bit about working with just regarding sexual sexual orientation and gender orientation, native LGBTQ and two-spirit concepts. One of the things that let me see if I need to back up there. Yeah, okay, we're okay. Again, in looking at lesbian, gay, bisexual, and transgender family networks, LBGT individuals may create replacement family networks that are made up of individuals who are significant to them when individuals who have passed on, or are no longer an immediate part of the patient's life because of addiction, HIV issues, a relationship breakup, or other life events. These replacement networks, family networks, could include friends, partners, families of partners, ex-significant others, or blood relatives. Like others, for example, in cases of other cultures, like gangs, for example, family networks are built very similarly for safety and support. Cultural considerations with native two-spirit peoples, although not universally recognized among all tribes, some may refer to the native LGBTQ community or other variations. This concept is not that there are actually two spirits in one individual, although this can happen. It really is there are two spirit teachings that teach of the two halves of each person, which is half male, half female, the goal of becoming androgynous. Each half may also have a various spectrum of masculinity or femininity, which is part of how they were created. Let's take a look at some stages of family change. And again, I'm watching my time to make sure we don't run out. Stages of family change. So again, I want to put this in the context of attainment of sobriety, adjustment to sobriety, and long-term maintenance of sobriety. There are different family dynamics that I want to consider as well. And again, I know for many of you this may just be a review, but it's important, I think, to identify some different terms and concepts related to family dynamics. One term was often used, the term codependence. Other words could be used would be dysfunctional families, and the verb that's often referred to is, we've all used this probably at some point, is enabling. Also, other family dynamics to consider: just control of others as they believe they're incapable of taking care of themselves, low self-esteem, and a tendency to deny their own feelings, and excessively compliant. These would all be family dynamics we might see and note. Family dynamics continued, often react in an oversensitive manner, hypervigilance, low tolerance for stress. They might remain loyal to people who do nothing to deserve their loyalty. And they may also feel less able or powerless to influence the family dynamics. I know there's a TED Talk on domestic violence and why people stay in those relationships if you're interested in that. For time purposes, we're not going to be able to view that. Okay, let's see if I can. Yeah, so again, codependency, I think, is something I want to just come back to. In its broadest definition, a codependent is someone who cannot function on their own and whose thinking and behavior is instead organized around the other person, process, or substance. In this context, people who are addicted to a substance, for example, or a process like gambling or sex, can also be considered codependent. In its most narrow definition, it requires one person to be physically or psychologically addicted, such as to an opiate, and the second person to be psychologically dependent on that behavior. I just wanted to kind of come back to that for a moment. So let's also look at patients' lives with a partner and minor children. We're going to go through some different possible family setups just to keep in mind how the family dynamic may change, be altered, or be impacted depending on who is in the family. So if you have a patient that lives with a partner and a minor and children who are minors, there's some things to keep in mind would be similar to maltreatment of victims. Children believe the abuse is their fault. Children feel guilty and responsible for their parents' drinking problem, and they may trust and intimacy are key child development issues. If you have the patient who is in recovery, early in recovery, or actively living with a partner and minor children. Now, let's say the patient lives with a partner and minor children, just to continue building on that. The family dynamic is at increased risk for mood and anxiety disorders. The family dynamic may also have increased rates of divorce, violence, and need for control in the relationship. And some children will also be very resilient and adapt to this dynamic. Adolescents who live with family of origin. So if you have an adolescent who may be actively using substances or struggling with co-occurring or comorbid mental health issues, you may see other aspects within the family dynamic, such as violent behavior, delinquency, psychiatric issues, risky sexual behavior, impulsivity, neurological impairment, and developmental impairment. The effects of substance use disorders, and I would add mental health disorders and behavioral health disorders, and family structures. So if you think about how those might affect a patient who lives with a partner, patient who lives with a partner and children, patient who is part of a blended family, older patient with adult children, or an adolescent patient with a family of origin. All of these different scenarios, family dynamic scenarios, are going to be impacted in different ways by substance use disorder, or mental health disorder, or behavioral health disorder. Okay. Let's talk a little bit about the clinician's involvement. There really are 4 levels of clinician involvement with families. And I would ask maybe that you can kind of identify as we go which one of these that you have probably had most experience with. I don't know if there are licensed marriage and family clinicians in the audience, or if many of you are just providing behavioral health or general substance abuse counseling services. But there are 4 levels of clinician involvement with families. Level 1 is minimal emphasis. of the family. And this really is noted as interactions with parents are institution-centered, not family-centered. Families they may not be regarded as an important part or area of focus, but the family members are dealt with for practical or legal reasons, so maybe they're obligated or mandated to be involved. The service provider may only be required due to mandates or practical necessity or legal obligation to involve them. The second level would be just more from a information and advisory standpoint. And this really would be noted by just have content information about families, parenting, and child development. So you're just more advising maybe on parenting techniques or just some peripheral support strategies. Feelings and support. Again, I think this is a little more involved. It understands individual and family reactions to stress and the emotional aspects of the group process. And brief focused intervention, level 4. This is really understanding the family systems theory and incorporating that as such in the process. Let's take a look at, and these are kind of new to me as well. I think at some point I may have been exposed to the 7 C's for couples and families in treatment, but I think these are interesting, and hopefully you can find them perhaps applicable in working with your own patients. 7 C's for working with couples or families. They're character features, cultural and ethnic factors, contract features, commitment, caring, communication, and conflict resolution. So let's take a look here. Character really just says the characteristics of a person that tend to be persistent and play a major role in defining that person. So these would be things that you could utilize and focus on during family or couples counseling. Seven C's, cultural and ethnic factors, variables that form the context in which individuals and couples exist. Surrounding cultural forces shape relationships. Remember that not all cultures view life, relationships, and family the same as you do, or as the counselor or clinician. So it's important to kind of check your own cultural biases, values, and beliefs as you begin to work with families or couples in therapy. Contract features. This really involves a set of implicit or explicit expectations that partners have concerning how they will define their relationship and relate with one another. An effective contract would be explicit, attainable, mutually agreed upon, and beneficial to both partners. I know at the clinic that I worked at, we had often had behavioral contracts, treatment contracts, or self-harm contracts, no self-harm contracts that were also followed this format. Another of the 7 C's is commitment. Pledged, devoted, or obligated, being involved with, remaining loyal to, and maintaining a relationship over time. And in this concept, there really were two types. There was stability and quality. These could be characterized perhaps by relationships that have had difficulty but are stable over time, or relationships that have had quality despite some challenges or time apart or not being able to be together as often. Another of the 7 C's is caring. A person's ability to express behaviors that promote emotional and physical intimacy, expressed through affection and intimacy, mutually pleasing activities, quality time together, enjoying a supportive and understanding friendship. And again, these 7Cs are really utilized and can be used as a guide into addressing some of these issues in family relationships or in couples relationships. So one of the other 7Cs is communication, and we know how important that is, certainly in a family setting, and even more so in a couples relationship. Positive daily communications equal relationship success. Negative communications are characterized by expression of negative feelings, and the message sometimes then is not heard by the listener. And if you've ever been in a situation like that personally, or seen that within your patients or their families, it can be really debilitating for making progress in family therapy. It's just important to remember that couples and families take that time to communicate to one another. Communication it's about meeting in the middle, making concessions and negotiating. Again, one of the other 7Cs is conflict resolution. I think this is the final one. Personal skills and interpersonal interaction patterns that promote effective decision making. And this acronym I thought was helpful as I was looking through this. Solve, stop, slow down, see the problem. O, outline options. L, look at consequences of options. V, make a vote. And E, evaluate. And just in summary, the 7Cs, just taking time to think through personal and relationship areas that helps identify strengths to build upon and goals to strive for. And these are all goals that I think we would like to see our patients work towards or have aspects of in our work with them. I also want to look at the notion of taking a family history, and I think it's really important that we're afforded this opportunity to gather information. Certainly, with all patients, it's important to know, what the rules of the family system are. Was there a history of physical, emotional, spiritual, or sexual trauma? Also being able to identify and flag were all family members expected to behave or evolve in a certain way, and understanding that what were the family's expectations in regards to careers, relationships, appearance, status, or environment. And then also was there ever discussion about intimacy in the family? And then looking also at LGBT patients, being aware or understanding whether there was anyone else in the family acknowledged as identifying as lesbian, gay, bisexual, or transgender. How did the family respond to other individuals coming out or being identified as LGBT? Is the patient out to his or her family? And then also just if the patient has come out, what type of response did they receive? I just think the family history is important. It gives you some context and allows you to adjust your approach and strategy in addressing family issues as you work with families or couples. Guidelines for working with LGBT families. These are pretty straightforward, but demonstrate support and understanding for the life partners and significant others. Be sensitive to the individual's self-identification. Be sensitive to the diversity and variety of relationships in the LGBT community. Demonstrate support and understanding for the life partners and significant others. Be sensitive to the individual's self-identification. And be sensitive to the diversity and variety of relationships in the LGBT community. And then just from a sort of an individual or organizational standpoint, because LGBT communities are often underserved, marginalized, or seen as invisible, it's important that treatment providers make a commitment to serving this population and incorporate the commitment into the organization's mission statement, philosophy, and service literature. Examine all aspects of a program for overt and covert expressions and perceptions of heterosexual bias. And then lastly, just make a commitment at every level of the program, from the board of directors to the direct service staff, to design and deliver services in a manner sensitive to the needs of LGBT individuals. Well, I think I was able to finish a little bit early, and I'm hoping that we have some time for questions. Sure want to thank everybody for taking time out of your day to listen and go through this information with me. Happy to take some questions if anybody has any. I see a question from Arlen. She says, do you use a screening tool to see if a person is assimilated, bicultural, or traditional before working with them? That's a great question, Arlen. I know Sean Bear, our co-director, has talked about those 3 different levels of being culturally involved. And I don't know of a screening tool to assess that. I think it sounds wonderful and would really be helpful so that a clinician could adapt and adjust their approach. But I'll follow up and ask Sean about that and see if there is in fact a screening tool, or maybe others in the audience know of something. Thank you for that question. That's a good point. Well taken.
And someone just asked if the material for this lecture will be available for download. The handouts are actually available underneath the chat pod. There's a files pod, and you'll see the one labeled handouts. You can click on that and download it right now if you want, or we actually will be emailing everybody following up in the next couple of days, and the handouts will be included in that, as well as a link to the recording of this webinar and the CEU request form as well.
Thanks, Kate.
Oh, and someone asked about an attendance certificate. So what we do is we send out an email to our system tracks those who registered and whether you attended or not. And so if you attended under the email that you registered under, you'll get an email that confirms your attendance. So I know for some of you, that's all you would need to show your hours that you attended a training, and so the language is in there to say, you know, how long this training is and that kind of thing. But then if you do need an actual CEU certificate, we have the request form that's in the files pod that you can also download. But we'll attach that in our email that we send out to everyone too, that you can submit to us to actually request a CEU certificate. We're actually we are in a bit of a waiting period to get our official word from NADAC, but they have let us know that they will backdate all of the webinars that we've been putting on for the last few months and everything. So we have to hold off on actually sending those certificates out at this time, but we can send the email confirming your attendance, and then as soon as we get word from NADAC, we'll be able to do the CEUs as well.
Thanks, Kate. Arlen asked a good question too, and I'm not sure if that is something that your agency that you work for, I'm not sure what type of work you're doing in the behavioral health field, but I think deciding whether to involve family or friends in the therapeutic process, I think is sometimes driven by policy of the agency and the request or need of the identified patient that you're working with. Sometimes involving family can be detrimental. Sometimes the family will not be supportive of the person's treatment engagement. So there are a lot of the factors to involve, to consider when involving family or friends in the treatment process. Certainly involving them peripherally or on a limited basis can be beneficial. But again, as I said earlier in the webinar, if you're not a trained family therapist, sometimes making a referral out or consulting with your supervisor before making a decision to work with a family member in conjunction with the patient is sometimes a discussion to have with your supervisor. I hope that makes sense, Arlen. It's a great question or a great comment. I don't know if anything's changed. I think when I think about that, your comment, I think more about it may depend on the agency itself or the population being served or the needs or request of the patient.
Well, thanks for noting that. I see some people are mentioning that they're attending with a few different people, so I'll try to make notes of that and put that in our attendance in case people ask for CEUs. And yeah, if there are other questions, please feel free to type them in as we're finishing up. I just want to remind everyone that we will have a survey that we will link you to as we close out. And if you actually don't make it to the survey, we'll include that link in the email we send to you as well. So watch for that in the next couple of days. And we just want to thank you all again for your time and for spending it with us. And we would really appreciate your feedback. So please take a few moments to fill that out. All right, and it looks like Arlen shared a link to a screening tool that the...
Yes, thank you for that, Arlen.
Yeah, so I think we'll finish up here. Steve, did you have anything else you wanted to say before we close out here?
No, I just want to say thanks again to everyone for their time and attention, and I enjoyed spending a little time with all of you this afternoon. And keep up the good work out there. And again, I can be reached here at the center, and I think Kate has my contact information available if anyone would like that. Thanks again, everybody. Have a good rest of the week.
Yes, thank you so much.